Hi, everybody. Welcome to Congenital Heart Academy. We are very happy to have you in this. That is going to be the last session of Congenital Heart Academy of this year. We want to thank you all for all the support during this year, our amazing speakers and our amazing panelists in this session and all the other sessions that Congenital Heart Academy has done so far. So we are very happy to have you today with us. Please follow us on social media, and then you're going to see what we're planning for next year. We have a lot of nice things to come, so we hope all of you can join. So today we are continuing with Dr. Anderson and amazing panelists with this anatomical session about the ventricular masses, and we are going to have two more in January. So every 2 weeks, we are going to have two more sessions about the normal anatomy, and then we are going to continue with the cardiac diseases. I'm sure we are going to have an amazing year with Dr. Anderson and all the amazing colleagues that are joining us on this new approach of these sessions. For next year, we're going to have Dr. Mary Cohen as well. Hopefully, Dr. Norma is going to continue his session as well. We are planning the big webinars, and we are planning to do a lot of things as a partner of the World Congress that are going to be in 2023. We have planned a lot of nice things for you guys for next year. So now with you, Dr. Anderson.
Well, thank you very much, Grace. To confirm what Grace has just told you, we're finishing off our session today for 2021 with today's session, which is going to concentrate on ventricular topology. And you will see as I introduce the contributions made by Diane and Justin, that we thought we might be able to complete ventricular morphology with today's session, but we realize that is not the case. So the first two sessions of next year, as Grace has announced, are going to be devoted to completing the ventricles. So on January the 7th, we will be discussing the ventricular inlets. On January the 21st, we'll be discussing the outlets. And then also, as Grace has told you, then we will work our way through the malformations. And you'll hear during today's presentation that we hope to expand on what you're going to see today, which are the spectacular contributions putting together the anatomy by Diane using specimens and by Justin using computed tomographic data sets. So it's a long session today. We've got quite a lot to get through. I think it is spectacular. We hope we're going to have a good discussion at the end. Grace tells me that she is moving off to holiday very shortly. So I am going to be coordinating the discussion at the end. But Grace, if we can, let's start the video and let's have the meat for today's session.
Perfect. Thank you, guys.
Well, good afternoon to you all, ladies and gentlemen. Today will be our final session for 2021. And as you see, we will be discussing the ventricular mass. I had hoped that we would complete our approach to normal anatomy with this particular session, but it transpires that there is much more to say about the ventricular mass that we can achieve in one session. So the first two sessions in January of 2022 will be devoted to the ventricular inlets first, and then to the ventricular outlets. So today, we're going to look at the overall arrangement of the ventricular mass. And we're going to concentrate on a particularly important topic, namely the topology of the ventricular mass. And to do this again, I'm going to be joined by Diane Spicer, who will be showing you autopsy examples, and by Justin Tretter, who has prepared some spectacular analyses of living data sets. So let's get on and look at what we mean by the ventricular mass. And what we are as junctions are true anatomic entities. And then I've told you we're going to concentrate on ventricular topology, because you will all be well aware that almost without exception, we find two chambers within the ventricular mass, and they are morphologically right and morphologically left. So the potential problem is how we distinguish between them. As you will see, that is where topology comes into its own. So in order to understand topology, first of all, we must work out how many components there are within each of those ventricular chambers. Now, you will all be aware that I've been doing this for quite some time now. And only recently have we begun to look, where do these components come from? Today, we're going to look at how they relate to each other. But what are those components? And here we come to a potential problem. Because when I started in this field, which was the beginning of the 1970s, conventional wisdom at that time was that we could discuss and consider ventricles as possessing sinuses and conuses. And there are still some who think about it in this way. But to me, when I began to analyze congenitally malformed hearts, particularly those that we now call the functionally univentricular arrangement, I came across problems. So let me share briefly with you the problems that confronted me at that time. Because I would look at hearts like this, many of you will immediately recognize that this is the incomplete right ventricle from a heart with classical tricuspid atresia. And at the time, and this was the early part of the 1970s, people would be calling that part sinus, and they would be calling that part the conus. And they would be very happy that this was a morphologically right ventricle. But you will also recall, I hope, that at the time, people also spoke about single ventricles. And when we had allegedly a single left ventricle, it was thought that the small chamber in that setting was not a right ventricle. And the essence, of course, of the so-called single right ventricle was double inlet atrioventricular connection. Now, I'd like you to bear this particular picture in your mind whilst I show you the next one. Because to my eyes, this small chamber is almost the same as the one I showed you a moment ago. And it has a part there that at the time we could call the sinus. We had another part there that we could call the conus. And if we make analogies to that chamber with tricuspid atresia, we would still be calling this a right ventricle. But here is the hooker. Because this small chamber is the incomplete right ventricle in the so-called Holmes heart, and the essence of the Holmes heart is double inlet left ventricle with concordant ventriculo-arterial connections. So at the time, we were forced to disqualify this chamber from having ventricular status, even though it was more or less identical to the chamber I showed you a moment ago from tricuspid atresia, which everyone was happy to call a right ventricle. And to me, that did not seem quite right. And so the solution to this problem that confronted us was to analyze the ventricles not in bipartite fashion, sinus and conus, but rather in tripartite fashion. And in fact, a surgeon at the time, Danny Gore, who worked in Israel, had been training in Minnesota with Lillahei, and Danny Gore had already suggested that we could analyze ventricles by considering their inlet, their apical trabecular component, and their outlet. And we immediately saw how we could put this to value when we were looking at functionally univentricular hearts. And as you know, and as we have discussed, the approach, the tripartite approach, has now been validated by what we know about cardiac development. So let's look again at what we now know from cardiac development. You've seen this picture several times now. You know that it's a reconstruction made by Professor Wout Lammers, Dr. Jill Hickspoors from the University of Maastricht, the Netherlands. And at this early stage, Carnegie stage 13, halfway through the 5th week of development, the atrioventricular canal is supported exclusively by the developing left ventricle. We can see the beginnings of the developing right ventricle, and the developing right ventricle is supporting the entirety of the outflow tract. So the inferences we can now make based on this information from development is that each ventricle begins with its apical part. And we've discussed how these apical parts balloon from the inlet and outlet of the ventricular loop. And we've also emphasized that at this early stage, the developing left ventricle has both inlets. The developing right ventricle supports the entirety of the outflow tract. So let's look at that again. I've shown you this picture before. It's an episcopic data set, and you can clearly see the atrioventricular canal supported by the developing apical part of the left ventricle, and then all the blood entering the left ventricle has to pass through the primary interventricular communication. It enters the developing right ventricle, forming from the outlet part of the ventricular loop, and as you've seen, it supports the entirety of the outflow tract. So we can make further inferences, because since the developing right ventricle supports the entirety of the outflow tract, it lacks this early to make the correlations between development and the malformed hearts. Because at this early stage, what we see is directly comparable to the pictures I've already shown you about showing functionally univentricular hearts with dominant left ventricles. So this is what that developing right ventricle looks like when you slice off its parietal wall and look at it from the front. So that is the cavity of the right atrium. There you see en face the primary interventricular communication, and we can very nicely now see the apical part ballooning from the outlet of the loop, and we see that the developing right ventricle is supporting the entirety of the outflow tract. Now, I hope you will recognize the similarity with what I've shown you of that small chamber in the setting of tricuspid atresia. The outflow tract, of course, is now separated, but we can now recognize that that apical part is forming the apical part of what is now the incomplete right ventricle, and that the outflow tract is divided to form the subpulmonary infundibulum remaining from the incomplete right ventricle, the aortic root committed to the dominant left ventricle. And in this stage, we have absence of the right atrioventricular connection because as yet, the right ventricle has not received its inlet component. So we can now make further inferences because during ongoing development, there is remodeling of that primary interventricular foramen. We've also looked at that, and we know it is expansion of the atrioventricular canal that gives the right ventricle its inlet, and then it is transfer of the aortic root that provides the left ventricle with its outlet. So let's look at that again. So now I'm showing you the outside of these wonderful reconstructions made by Wout and Jill. So here you're standing behind the heart, this early stage, Carnegie stage 14, and there you see in yellow the atrioventricular canal myocardium. And still at this early stage, the atrioventricular canal myocardium is supported exclusively by the developing left ventricle. So there you see the myocardium enclosing the developing right ventricle, and it's supporting the entirety of the outflow tract. We go on 2 stages, and we see what has happened subsequent to expansion of the atrioventricular canal, because now expansion of the atrioventricular canal has provided the right ventricle with its own inlet. We can go a couple of stages further. We can tilt the data set so we can look down now on the atrioventricular canal from above, and we can see clearly that that expansion has given the right ventricle its own inlet. We can also see that the cushions separating the atrioventricular canal have themselves fused. They've draped themselves across the crest of the ventricular septum. Growth of the vestibular spine has produced the buttress of the atrial septum, and now we have separate atrioventricular orifices so that each ventricle now has its own inlet. But as yet, the left ventricle has not got its own outlet. And we can see how the aortic root is transferred to the left ventricle. So this again is a picture I've shown you before. It happens after the transfer of the inlets. We're at 7 weeks into development now, and you're looking at the right ventricle from the front and the side, having taken away the parietal walls, and we can see how the proximal cushions are muscularizing to form the shelf in the roof of the right ventricle that tunnels the aortic root into the left ventricle through what is now the secondary interventricular foramen. I've shown you this before. This is the histological section that shows you the aortic root, and we know that it becomes connected to the left ventricle by the formation of that shelf in the roof of the right ventricle, even though it is still aligned with the right ventricle. And we can see that very nicely in the final stage, prior to the fetal stage of development. Again, the reconstruction made by Wout and Jill. You're looking at it from the front. You see the aortic root is still aligned with the right ventricle, but is connected to the left ventricle by the formation of that shelf in the roof by muscularization of the proximal cushions. And we know that the final stage in commitment of the aortic root to the left ventricle is the closure of the tertiary part of the interventricular communication by the membranous septum. And that turns the secondary interventricular communication into the left ventricular outflow tract. And what Justin is going to show you eventually is how in double outlet right ventricle, that secondary interventricular communication can remain as the outflow tract for the left ventricle, the interventricular communication. Now, one of the other problems in getting to grips with cardiac development of anatomy was the suggestion by Dr. Van Praag that there were connecting segments. And indeed, we know there were connecting segments as the heart develops, but we also know that the atrioventricular canal myocardium is sequestrated in the atrial chambers as the vestibules of the atriums, and that those proximal cushions remodel to form the conuses, and they are then committed to form the outflow tracts of the two ventricles, giving us eventually an atrial segment, a ventricular segment, and an arterial segment. So let's look now in more detail at the ventricular mass, because we now know that subsequent to the sequestration of the atrioventricular canals, the vestibules, it extends from the atrioventricular junction to the ventricular arterial junction. And Diane and Justin will be showing you very shortly these junctions in the definitive heart. But I can show you how, as suggested by Daniel Gour and his work with Lillehei, we can divide the ventricles into an inlet, an apical part, an outlet, seen very nicely here from the right ventricle. And then if we look at the left ventricle, again, taking the mass as extending from the atrioventricular to the ventricular arterial junctions, we can recognize the inlet, the apical trabecular component, and the outlet. I'm showing you pictures. It's much better if we see this in moving hearts demonstrated to you. So now we're going to see this tripartite arrangement of the ventricular mass shown to you, first of all by Diane in specimens, and then by Justin in virtue.
The ventricular mass contains two ventricles. The anterior-most ventricle is the right ventricle, and the posterior-most ventricle is the left ventricle. When we look at our ventricles, we look at them in a tripartite fashion, so we analyze the inlet, the apical trabecular component, and the outlet. The ventricular myocardium extends from the atrioventricular junction to the ventriculo-arterial junction. Within the inlet of a morphologically right ventricle is a tricuspid valve, and it too is a morphologically right structure. The tricuspid valve has attachments to papillary muscles and to the interventricular septum. The inlet component of the ventricle is marked from the hinge point of the atrioventricular valve to where the tendinous cords attach to either the septum or the papillary muscle. The morphologically right ventricle is characterized by its coarse apical trabecular component, and very often the septal surface is trabeculated as well. One of the most prominent trabeculations within the right ventricle is the septomarginal trabeculation, and it has a cephalic arm which rises up to become part of the subpulmonary muscular infundibulum and support the pulmonary valve, and the caudal arm which extends to connect with the inner heart curvature, and it gives rise to the medial papillary muscle, which supports the zone of apposition between the septal leaflet and the anterior leaflet of the tricuspid valve. Also arising from the septomarginal trabeculation is the moderator band, which has been cut away from where it joins the anterior papillary muscle, and you can see where it crosses the right ventricular chamber if I put it back together. Also arising from the septomarginal trabeculation are the septoparietal trabeculations. The pulmonary valve is supported by this complete muscular infundibulum or muscular sleeve, and in the right ventricle, this muscular infundibulum separates the atrioventricular from the arterial valve. The pulmonary valve is made up of 3 semilunar leaflets, and each of these leaflets crosses the ventriculo-arterial junction. I have another specimen where I have removed the pulmonary valvar leaflets, and we can see the true components of that ventriculo-arterial junction. It is circumferential within the right ventricle, where you can see the distal extent of the subpulmonary muscular infundibulum, where it joins the fibrocollagenous wall of the pulmonary trunk. And in the base of each sinus, we have a small crescent of muscle. The posterior-most ventricle in a normal heart is the morphologically left ventricle, and typically the myocardium within the left ventricle is thicker than that on the right. We'll look at this in a tripartite fashion, just as we did with the right ventricle, and the mitral valve lies within the inlet of the left ventricle and is a morphologically left structure, so it will always travel with a left ventricle no matter where it's located within the heart. The mitral valve has the anterior or aortic leaflet because it is in fibrous continuity with the aortic valve. This leaflet makes up about 1/3 of the mitral valve circumference, and it is a very broad leaflet. The remaining 2/3 is composed of this much more shallow leaflet, the mural leaflet, a portion of which is over here on the cut surface or septum, and both papillary muscles equally support each of the leaflets. The inlet within the left ventricle is from the atrioventricular junction or hinge point of the mitral valve to where the tendinous cords attach to the tips of the papillary muscles. So the left ventricular myocardium extends from the hinge point of the mitral valve to the ventriculo-arterial connection. The morphologically left ventricle is characterized by its fine crisscrossing apical trabeculations, and typically the septal surface becomes smooth as it extends up towards the aortic valve. Again, here you can see that there are no septal attachments of the mitral valve, and another important point to make is that the anterior leaflet of the mitral valve is all that separates our left ventricular inlet from our left ventricular outlet. And if you remember, we had the subpulmonary infundibulum separating the atrioventricular from the arterial valves within the right ventricle. Here we can see the area of the right fibrous trigone and the left fibrous trigone where the mitral valve is anchored at its fibrous continuity with the aortic valve. And between the non-adjacent or the non-coronary aortic valvar sinus and the right coronary aortic valvar sinus is our membranous septum. You can see the left coronary artery and right coronary artery arising fibrous support for the aortic valve. I have another specimen where I have removed the aortic valve leaflets, and we're able to see where the muscular ventriculo-arterial junction and the fibrous junction is located. So within the left coronary aortic valvar sinus, we have a small crescent of muscle, and within the right coronary aortic sinus, we have again another small crescent of muscle between the base of the left ventricle and the fibrocollagenous wall of the aorta. So there's the right coronary. Our non-adjacent or non-coronary sinus, as well as a portion of the left coronary aortic valvar sinus, is supported by the fibrous continuity between the mitral valve and the aortic valve. And again, here is our right fibrous trigone and the membranous septum.
So we'll go over a few examples of computed tomographic data sets to better understand the tripartite assessment of both the right and the left ventricle. We've seen this data set before. It's an adult patient with normal segmental anatomy, but with severe aortic stenosis and resulting left atrial and left ventricular dilatation and left ventricular hypertrophy. We can appreciate that even though the left ventricle is heavily trabeculated for a normal left ventricle, we see these important structures of the inframedial and the superior lateral papillary muscles with no clear attachments to the ventricular septum. Looking at the right ventricle, we can appreciate the anterior papillary muscle and the inferior papillary muscle. And looking at the base of the anterior papillary muscle, and as we start to dissect anteriorly, we can see the attachment of this moderator band to the base of the anterior papillary muscle here. We'll continue to dissect anteriorly, paying attention to the right ventricle, and then we'll rotate over into more of a right anterior oblique view, looking at this moderator band attachment to the base of the anterior papillary muscle. We'll come all the way over into right anterior oblique view with the free wall of the right atrium and right ventricle removed, looking at the rightward aspect of the atrial and the ventricular septum, and paying attention to the ventricle, appreciating its tripartite anatomy. So here's the septal leaflet of the tricuspid valve and with its chordal attachments to the septum. And this important structure we talked about before, the medial papillary muscle or papillary muscle of Lancisi, which is attaching right somewhat anterior to its usual location at the posterior caudal limb of this structure here, the septomarginal trabeculation. So the septomarginal trabeculation dividing into its anterior cephalid and posterior caudal limb with this medial papillary muscle attaching here at the base of the posterior caudal limb. And then if we rotate further, you see this unusual, almost bifid appearance of a moderator band, but it's attaching to the base of the anterior papillary muscle and attaching at the septum at the base of the septomarginal trabeculation. Looking at the papillary muscles, we can see they're much more coarse, or the trabeculations are much more coarse when we compare it to the left ventricle. So we can easily define the Coming back to this right anterior oblique view, we can easily define the inlet component extending down to the chordal and papillary muscle apparatus attachments to the septum. So that defines the inlet up to the annular attachment of the tricuspid valve, the apical trabecular extending from the inlet down to the apex and up to the outlet. The outlet we define by looking at the septomarginal trabeculation and its limbs, cradling between its limbs the ventricular infundibular fold and the supraventricular crest, with the outlet extending from the limbs of the septomarginal trabeculation and then anterior and superiorly up to the outflow or to the pulmonary root. So here we see the semilunar attachments of the pulmonary root, and we can appreciate this darker appearance of the ventricular myocardium versus the arterial wall. So this anatomical ventricular arterial junction, which in the pulmonary root is a circumferential structure. And then we'll rotate over, now cutting in a short axis, looking from the apices of both ventricles up at the right ventricle and the left ventricle, seeing both inlets of the ventricles and then seeing the outlet of the right ventricle leading up to the pulmonary root, better appreciating this ventricular infundibular fold and supraventricular crest. And now looking over at the left ventricle. So the left ventricle, as we all know, has two papillary muscles, the superior lateral and inframedial papillary muscles, or commonly referred to as the anterolateral and posterior medial. But when we look in an attitudinally correct fashion, we can appreciate how they're positioned more superior and inferiorly. And those support the aortic leaflet and mural leaflet of the mitral valve. And then going into a three-chamber view, we can better appreciate the tripartite nature of the left ventricle, with the inlet again extending from the annular plane of the mitral valve down to its chordal and papillary muscle attachments, the apical trabecular component extending from that plane down to the apex and then up to the outflow, with a much smaller outflow than the normal right ventricle, related to the development with resorption of the subaortic infundibulum, leading to this important relationship, the fibrous continuity between the aortic leaflet and the mitral valve and the aortic valve. So a much smaller outlet. And importantly, even though heavily trabeculated left ventricle compared to normal, there's a very smooth outlet compared to when we look back at the right ventricle, where we have those septoparietal trabeculations between the septal marginal trabeculation and the free wall of the right ventricle. So very trabeculated right ventricle extending not only down from the apex, but all the way out to the outflow to the pulmonary valve. So coming back to this three-chamber view for comparison. So next we'll go to another data set. So this is an infant patient, and we'll start to dissect from the anterior chest. We'll rotate into a right anterior oblique view, removing the free wall of the right atrium and the right ventricle, looking at the rightward aspect of the atrial and ventricular septum. So we can appreciate the floor of the oval fossa, and if we tilt it a little bit, you can somewhat get the sense of the small secundum atrioseptal defect. But then you additionally see this other atrial communication. So this is an atrioventricular septal defect with a common atrioventricular junction. And this has large atrial level shunting above the atrioventricular valve. Here's the superior and the inferior bridging leaflets. And if we rotate this heart, looking down at the chordal apparatus of this AV valve, you can see there's very small ventricular level shunting between the chordae of the superior and the inferior bridging leaflet. So very small restrictive ventricular level shunting to this atrioventricular septal defect. But then looking at the anatomy of the right ventricle, we see the same tripartite nature. The inlet extending from the common AV junction down to the attachments of the chordal support and papillary muscle support of this common AV valve. And there we can see the medial papillary muscle attaching to that posterior caudal limb of the septomarginal trabeculation, dividing into that posterior caudal and anterior cephalad limb, cradling again the ventricular infundibular fold and the supraventricular crest. But we'll see in this anatomy, the aortic root has now been unwedged from the common AV valve with a so-called gooseneck deformity and elongation of the left ventricular outflow tract. So looking at the apical trabecular component extending from the inlet down to the apex and then up to the limbs of that septomarginal trabeculation, the outlet extending from within the limbs up to the pulmonary root. Again, seeing the trabeculations extending all the way up to, along these septoparietal trabeculations up to the pulmonary outflow tract. Here we're cutting the moderator band that's coming out towards us. So it's attaching at the base of the septomarginal trabeculation. And we saw before that it is attaching to the base of this anterior papillary muscle. Now going over to the left ventricle, looking up from the apices of the ventricles up at the common AV junction, we can appreciate that the junction in the common AV valve is primarily opening up into this relatively large or dilated right ventricle with very little of this common AV valve opening up into the left ventricle. Now looking at the left ventricular papillary muscles, we can appreciate that they have more of a superior-inferior relationship, being at 12 and 6 o'clock, as opposed to in the normal heart, where they're positioned more at 2 and 7 o'clock, a common feature of common AV septal defects. And then we'll dissect into a 3-chamber view. And as we do, you can appreciate the much smoother septal wall of the left ventricle. And looking at the apex, we see these more fine trabeculations in the apex of the left ventricle, a somewhat hypoplastic left ventricle in this RV dominant AV septal defect. And then a defect with primarily atrial level shunting. And then, as I mentioned, an elongated left ventricular outflow tract with this gooseneck deformity related to the aortic root being unwedged from between the atrioventricular junction. So here's the aortic root, much greater distance when we look at the outlet measurement of the left ventricle related to the inlet measurement. So a common feature, but still retaining its tripartite nature. And then lastly, we'll look at an infant that has double outlet right ventricle. So we're starting in this similar right anterior oblique view with the free wall of the right atrium and right ventricle removed. We see a large secundum ASD focusing on the right ventricle. Here we're cutting in, we're still seeing the anterior leaflet with part of its papillary muscle support. The septal leaflet is just behind this. And so here is defined the inlet of this right ventricle down to its chordal and papillary muscle attachments, the apical trabecular component extending down to the apex. And then here's the septomarginal trabeculation with a large interventricular communication between its limbs, the anterocephalid and posterior caudal. Importantly, the posterior caudal limb is intact with muscle, so defining the borders of this interventricular communication, it's exclusively muscular borders, since we have infundibulum under this relatively larger pulmonary root, along with subaortic infundibulum under this relatively smaller pulmonary root. So muscle surrounding the borders of the defect. It's located in the outlet within the limbs of the septomarginal trabeculations. So it is a muscular outlet defect. And I'm calling this an interventricular communication because at the roof here is a ventricular infundibular fold. The margins of the actual ventriculoseptal defect, the superior margin, is formed by this prominent structure, which is the outlet septum between the pulmonary and the aortic root. So the ventriculoseptal defect plane defined by drawing a line from the crest of the ventricular septum up to this outlet septum. Hemodynamically, this interventricular communication looks to be pretty fairly committed between both the pulmonary root and the aortic root. So many would describe this hemodynamically as being doubly committed between both great vessels, but not to be confused with the border definition of doubly committed, where there would be fibrous continuity between the great arteries. So moving forward from this right ventricular outflow tract view, and we immediately see the anterior papillary muscle supporting that anterior leaflet, extending down to the free wall with this moderator band attaching to the septum at the base of that septomarginal trabeculation. And then coming over to a 4-chamber cut. We can again see that anterior papillary muscle with the moderator band. But looking at the left ventricle, we see both the papillary muscles here and here with no attachment to the ventricular septum. And then as we move into looking at the left ventricle, we'll cut into a 2-chamber plane, looking at both of the papillary muscles, and then we'll start to move anteriorly to look at the septum of the left ventricle, appreciating that there's no chordal or papillary muscle attachments to the ventricular septum. The inlet extending from where those papillary muscles attach down to the apex of the and then the apical trabecular extending from where those chordal muscles attach down to the apex and up to the outflow. And the outflow being defined by the area leading up to the interventricular communication. And again, appreciating this very smooth-walled septum of the left ventricular aspect of the interventricular septum.
So now you've seen in some detail how the normal heart, the majority of abnormal hearts, almost always contain 2 ventricular chambers. It is as rare as hen's teeth to find ventricular masses with solitary chambers. But you've also seen that not always do those individual ventricles possess all their components. Justin has just shown you a very nice example of a heart with double outlet right ventricle, where the left ventricle is lacking its outlet component, with the interventricular communication serving as the ventricular outlet. And I've shown you examples of tricuspid atresia where the right ventricle lacks its inlet. So we need to know about these component parts, because analysis and description of the arrangements is helped by recognizing those parts, and particularly by appreciating their topology. So what is ventricular topology? Topology is the way in which the ventricular components relate to each other within the context of their individual chambers. Because the right ventricular inlet can belong only to the morphologically right ventricle. It has its own topological, 3-dimensional arrangement. By the same token, the left ventricular inlet belongs only to the left ventricle, and by extension, the right ventricle and the left ventricle are mirror images of each other when we consider their topological arrangement. So how do you, as clinicians, work out this topology? Well, we can do it by going back to the normal heart, and we can think of the way in which the chambers relate to each other. So what I'm going to show you is how normally the right ventricle wraps itself round the left ventricle. And it does so in left to right fashion. It then follows that if we mirror imaged it, it would wrap around in right to left fashion. So let me show you in the normal right ventricle. So here we're looking at it from the front, and then we see the inlet to our left hand. And then as we move from the inlet, which has its own topological arrangement, towards the outlet, we move from the left hand towards the right hand. And then as we move to the outflow tract, we move superiorly. And this is the topological arrangement for the normal right ventricle. And the key to topology is that we cannot change these relationships by tilting or by rotation. We can, however, change them by mirror imaging them. And I can mirror image this picture, as you see here, and now we see what the right ventricle would look like if it was in a patient with mirror-imaged atrial arrangement and concordant atrioventricular connections. I've done this simply by mirror imaging the picture itself. But now we see the inlet to our right hand. And now the movement is from the right hand to the apical trabecular component seen to our left hand, but once more we have to move superiorly to reach the outlet. The topology is the mirror image of the normal right ventricle. And we can only get this topology by pure mirror imagery of all of those components. So this mirror imaged tricuspid valve will only fit within a mirror imaged right ventricle. The normal tricuspid valve, which is the production of D bulboventricular looping, will only sit in the normal right ventricle. And this is so important because this is the key to topology. So the interrelationships of those ventricular components will be constant, irrespective of how the heart itself moves within three-dimensional space. And that is the beauty of topology. And you will also appreciate that in the normal heart, the left ventricle itself will be a mirror image of the right ventricle. But by convention, we determine topology by looking at the morphologically right ventricle. But if we wanted to, we could look at this left ventricle. And you see now the inlet is seen to our right hand, it moves towards our left hand to give the apical part, and then superiorly to the outlet. We could use the left ventricle, but by convention, we use the right ventricle. So when we have a left-handed left ventricle, it goes along with a right-handed right ventricle. And so we base topology on the arrangement of the morphologically right ventricle. It then follows that within the normal heart, the two ventricles together make up a unit. So to emphasize again, we account for the topology of the overall heart by looking at the morphologically right ventricle. And again, for emphasis, the topologic arrangement of that right ventricle will be constant irrespective of how we move it within three-dimensional space by twisting, by tilting, or by rotation, because we cannot mirror image the ventricle itself by twisting, tilting, or rotation. And to emphasize again, we could, if we wanted, simply look at the tricuspid valve to determine topology, because the tricuspid valve has its own topological arrangement, and a right-sided topological tricuspid valve will only sit within a morphologically right ventricle. Now, it's relatively easy for me as a morphologist to do this because I determine topology by placing the palmar surfaces of my hands on the septal surface of the right ventricle, such that I can place my thumb in the inlet, the fingers in the outlet. And this permits me to distinguish between the right-handed and left-handed patterns. So let's look again at this normal right ventricle. And I now have to figuratively try to put the palmar surfaces of my hands on the septal surface of this right ventricle. And there you see it is my right hand that goes on the septal surface, and the dorsum of my right hand is now against the parietal surface of the right ventricle. But I could, if I wanted, simply have said that this is a right-handed right ventricle because my thumb goes in the normal tricuspid valve. If I cut off my thumb, I could only put it back on my right hand because my right thumb will not fit on my left hand. It is only my left thumb that sits on my left hand. And this is the essence of topology. So here again is my mirror imaged right ventricle. And now, having mirror imaged the ventricle, it is only the left hand which will fit on its septal surface.
For the purposes of this video, you can see that I've removed the right hand glove from this packet of surgical gloves. And with the drawing on the packet, you can also see that our hands are mirror images of one another. If we look at the ventricles, and here we see the right ventricle, It is a three-dimensional structure, and I can remove the free wall to look at the septal surface. When we look at the septal surface, we see the septal leaflet of the tricuspid valve, the apical trabecular component, and the pulmonary valve in the outlet. And if I take that right glove, you can see it, or your hand, is a three-dimensional structure, and you can put the palmar surface of the right glove on the septal surface of the right ventricle with the thumb in the inlet and the fingers in the outlet. With the glove as a three-dimensional structure, I can place that right ventricular free wall on the dorsal surface of the glove and actually ventricular topology. If I place the right ventricle in left-sided position, even though this is anatomically impossible, you can still see that the thumb goes in the inlet and the fingers to the outlet with the palmar surface on the septal surface. So this shows that this ventricle has right hand ventricular topology, and even the free wall can demonstrate right hand ventricular topology when it is placed on the dorsal surface of the right-handed glove.
So now, although the concept of handedness for the morphologist with heart in his or her hands requires no more than to relate the components, as I say here, to each other, it is not that easy for the imager. Is this indeed the case?
So now to talk about the topology, put the heart in a Valentine orientation, standing up on its apex, and I'll rotate it into a right anterior oblique view, looking at the free wall of the right ventricle in this normal heart. We'll start to dissect into the heart, into that right anterior oblique view, removing the free wall of the right atrium and right ventricle, looking at the rightward aspect of the atrium ventricular septums. And we see all the same anatomy we've been going over in exquisite detail. And the important concept here is if we think about the handedness, and I put my palm of my right hand on the ventricular surface so that my thumb is going out the inlet and my fingers out the outflow, I can only do that with my right hand. And if we start to rotate this around in an unnatural 180-degree rotation, so now our diaphragmatic surface is facing superiorly, that has not changed the topology of the right ventricle and how it relates to the left ventricle. Even though I can't really bend my arm in this way, the only hand that I can fit, so my palm is up against the ventricular surface, my thumb out the inlet and my fingers out the outflow, is my right hand. So it retains its right hand ventricular topology. And so I'm going to rotate this back. And so where this really becomes difficult for the imagers to understand is when we're dealing with very complex congenital heart disease, such as found in isomerism or found in hearts with twisted atrioventricular connections. And so what may be more helpful is trying to think about the ventricle as a three-dimensional entity. And instead of thinking about handedness, trying to think about it, the ventricle as a glove. And so here, if we cut the apex of the ventricle away, so now you can see in the background, the left ventricle apex has been cut away and the apex of the right ventricle. And then we've cut at the ventricular arterial junction and at the atrioventricular junction. And if we color code this similar to the glove that I have on the right-hand side, where we have the cut apex colored in yellow, we have the outflow cut in green, and the inlet cut in purple. And then if we put the free wall back on and then make the free wall translucent so we can better understand this three-dimensional structure analogous to a glove, and we want to be able to fit our hand into the glove, into the apex, and then put our fingers out the outflow and our thumb out the inlet. And no matter how we rotate this heart, the only way that we can do this in this normal heart is with our right hand. So again, making the myocardium translucent, this time keeping the septum so we can see it, to place our palm against the septum. And no matter how we rotate this, so if I rotate like this, the only way that we can get our hand through the apex, through the yellow, and then get our fingers out the green, out the outflow, and our thumb out the inflow, which is the purple, is by using our right hand, no matter how we rotate this heart. So thinking about more of this idea of a glove in a three-dimensional structure can help us to better define the ventricular topology when dealing with more complex anatomy. So looking at a few patients, this is an infant that we looked at before with left atrial appendage isomerism. So here we're looking at the base of the heart with morphologically a left atrium on the left and a left atrium on the right. So left atrial appendage isomerism. And we won't look at too much of the detail of the anatomy, but looking now, rotating into that right anterior oblique view, removing the free wall of the right ventricle. Here we see the tricuspid valve with its chordal attachments and papillary muscle attachments. Here, the anterior papillary muscle supporting the anterior superior leaflet of the tricuspid valve. Here, the medial papillary muscle attaching that septomarginal trabeculation with its posterior caudal limb. So this is a morphological right ventricle that's positioned rightward and anteriorly. And we can see that tripartite nature that we discussed. And again, if we think about that glove concept, if we cut the apex, the only hand that we can put through that glove and get our thumb out the inflow and our fingers out the outflow and keep our palm on the septal surface is our right hand. And then if we rotate this into a 4-chamber view and then over into a 3-chamber view to look at the left ventricle, you can appreciate that smoother ventricular surface of this left ventricle. We'll come into a 3-chamber view here. And now looking at the morphological left ventricle, which is positioned leftward and posterior. If we cut the apex off and we put a hand in to put our thumb out the inlet, our fingers out the outlet, and keep our palm on the septal surface, the only hand that we can do it in this left ventricle now is our left hand. So again, confirming, since we use the right ventricle as a standard to define topology, then this is right hand ventricular topology. And then looking at, lastly, an adult patient that has congenitally corrected transposition. And we can easily appreciate here in this 4-chamber view with very heterogeneous opacification, unfortunately, on the right side of the heart in the right atrium in the morphological left ventricle. But we can appreciate the tricuspid valve here, which is positioned left and posterior. We know that this is a right ventricle, not only with these septal attachments of this tricuspid valve, but also this important structure, the moderator band. So this is a morphological right ventricle that's positioned leftward and posterior. And if we rotate now into a 3-chamber view of this morphological right ventricle, so tricuspid valve, the inlet, the apical trabecular, and the outlet, if we cut the apex of the heart and we try to put a hand in like a glove with our thumb out the inlet, our fingers out the outlet, our palm on the septal surface, the only hand that we can do this now in this morphological right ventricle is our left hand. So this defines left ventricular topology. And then a little more difficult because of the heterogeneous contrast opacification, but now if we rotate into that anterior and rightward ventricle, that is the morphological left ventricle, we can appreciate the smooth septal surface. There's unopacified blood coming up from the IVC mixing with the superior cable vein, but this is the mitral valve and the atrioventricular junction. So this is the inlet, the apical trabecular, and then the outlet going up to the pulmonary root. And the only hand that we can, if we cut the apex off and try to put a hand through this glove with thumb out the inlet and fingers out the outlet, the only hand that we can do it in this morphological left ventricle is our right hand with our palm against the septal surface. So again, confirming the left hand ventricular topology in this patient with congenitally corrected transposition.
But why is topology so important? It's important because the mirror image patterns of right-handed and left-handed topology are themselves equivalent to D-looping and L-looping of the ventricular mass. And almost without exceptions, when we have concordant atrioventricular connections with usual atrial arrangement, we have a D-loop. When we have discordant atrioventricular connections with usual atrial arrangement, we have an L-loop. And then we can say the topological arrangement is harmonious with the connection. But sometimes that is not the case. Very rarely there can be disharmony between the topological arrangement and the connections. And that is when we need to describe not only the connection, but the topological arrangement. So I'll show you a very rare example of disharmony between the atrioventricular connection and the ventricular topology. Now, it's a little difficult to know what's going on here. For unfortunately, I no longer have this heart available. All I have is this picture that was taken a long time ago. But that is the inlet to the morphologically right ventricle. The apical part is coming towards us. And remember, if it's an L loop, we go from the right hand towards the left hand as we move to the apical trabecular component. And that is what is happening here. And then we go superiorly to the outlets. So this is a left-handed ventricular, a left-handed morphologically right ventricle. The problem in this heart is that the inlet does not connect to the morphologically left atrium as we would expect, because we would expect this to be congenitally corrected transposition. In fact, in this heart, the inlet tricuspid valve is still supported by the morphologically right atrium, which is usually arranged. So this is a rare heart that has segmental disharmony, but with twisted atrioventricular connections. There is usual atrial arrangement, the atrioventricular connections are concordant, and there is then double outlet right ventricle. But in addition, there is left-handed ventricular topology. If I describe it in this way, hopefully you will understand what I'm talking about. It's one of these very rare examples with segmental disharmony. But there is one more situation in which we have to take account of ventricular topology. And that is when there are isomeric atrial appendages. Because when you have isomeric atrial appendages and biventricular atrioventricular connections, half of the heart is going to be concordantly connected, the other half is going to be discordantly connected. So let me show you that. So here in the diagram, I am showing you isomeric right atrial appendages. And I'm showing you the situation where those isomeric right atrial appendages are connected to a heart which has the right ventricle to the right, the left ventricle to the left, right-handed ventricular topology. So properly to describe this heart, I have to say there is both right isomerism and right-handed topology, because the atrial chambers of this heart with isomeric right atrial appendages could just as easily be connected to a ventricular mass with left-handed topology. So these connections are biventricular and mixed. The only way of distinguishing between them is also to describe the topology of the ventricular mass. And now Diane is going to illustrate to you how we can still, in this setting, recognize the ventricular topology in the setting of isomeric atrial appendages.
Here we have a specimen that has isomerism of the left atrial appendages. You can see that the apex is pointing to the right. The atrioventricular connections in this heart are biventricular and mixed. On the left, we have a morphologically left atrial appendage and atrium connected to a left-sided morphologically right ventricle. The pulmonary trunk arises from this left-sided morphologically right ventricle so that the ventriculo-arterial connections are concordant. It's also important to point out that the topology of this heart is left-handed, so that I can only place the palm of my left hand on the septal surface of this right ventricle with my thumb in the inlet and my fingers in the outlet. If we look at the right-sided morphologically left atrial appendage, it is connected in concordant fashion with a right-sided morphologically left ventricle, and then it gives rise to the aorta, so that half of the atrioventricular connections in this heart are concordant and half are discordant. It's extremely important to describe the topology in these hearts with isomerism so that this heart has left-hand ventricular topology. Here I have a specimen that is a cardiac explant. You can see that the majority of the arterial trunks and the atriums have been removed. The apex did go to the left, and looking on short axis, we can see that the specimen has isomerism of the right atrial appendages, so that we have pectinate muscles surrounding each of the atrial vestibules and extending to the crooks of the heart. This specimen has a common atrioventricular junction, and as well has biventricular and mixed atrioventricular connections. One of the connections will be concordant and one will be discordant. So on the right, we have a morphologically right atrial appendage that is connected to a morphologically right ventricle on the right side. This right ventricle also has a double outlet, and we can also easily determine topology by placing the palm of my right hand on the septal surface with my thumb in the inlet and my fingers in the outlet. The opposite atrioventricular connection shows us a left-sided morphologically right atrium connected in discordant fashion with a left-sided morphologically left ventricle. With hearts that have isomerism, one of the most important descriptive features is to note the ventricular topology.
So there we have it, ventricular topology. Is it always possible to determine ventricular topology? I think that is always the case when we have biventricular atrioventricular connections. I think it is now possible to do that simply by taking note of the topological arrangement of the ventricular inlets. But that means both ventricles must have their inlet. So I'm not sure that it is always possible to determine topology when there is functionally univentricular connection and it is the dominant, and the ventricle that is dominant is the morphologically left ventricle. And that is because in those settings it's not possible to anchor the thumb. And it is the thumb that is the key to determining ventricular topology. That is what we do when we place it, figuratively speaking, into the tricuspid valve. With this one exception, in functionally univentricular hearts of left ventricular type, I do believe it is possible to determine the topological arrangement, and even in that setting, we can make inferences by knowing the relationships between the dominant and the incomplete ventricle. So, what we have shown you today, the ventricular mass, almost without exception, contains two ventricles, and those ventricles are of right and left morphology. I hope we have persuaded you that it is best to describe those ventricles in tripartite fashion, and then on the basis of what we know from that, we can determine how best to determine the topology. And as you have seen, as Justin has shown you, we can now liken that to the hand going into the glove being placed within the ventricle. And any of you can play with your gloves because you can move them around And if you play with a pair of gloves, you will be able to see that you can never change the topology of the gloves themselves by rotating or tilting them. Topology can only be changed by disassembling the parts and putting them together in appropriate fashion. In essence, it is making a three-dimensional jigsaw puzzle. So 3 parts to the ventricles. Today we have discussed topology. We still have to describe the valves, and that is what we will do when we start next year's presentations. So in January, we hope you will come back when we're going to take the same approach to the normal inlets to the ventricles, the mitral, tricuspid valves, the normal outlets, the aortic route, pulmonary route. So that's the end of the sessions for 2021. We hope you will all join us again as we start again in 2022. Well, thank you, Amina. I don't know, it seems that I am now the host. I depend on Amina to pull people through at the right time because we have a panel with whom I'm hoping to discuss various things. But I think Adrian Krushan. Adrian, are you there? Adrian, are you with us?
Hello, can you hear me?
Yes, I can hear. Yes, and we can see you.
Perfect.
So Adrian, you are going to lead off the discussion if you can.
Well, I enjoyed very much the presentation. I had the privilege to actually see the slides in advance. And I think the case of topology is well made. And I know that there are some background discussions and I'm interested to hear those, but I will just add a couple of things. Probably the advanced imaging that we are going to do in those functionally univentricular hearts will show that even in those hearts, there is always a small ventricle. So we can actually have the reference between the two ventricles, because whether it's a glove or a hand or a palm or however we want to call it, what's important is the referencing that happens between the two hands. Is not only one palm versus the other. Because, for example, I can show my right hand wrapped around the left ventricle, then the relationship between these two will not change however we tilt, rotate, move, look at the heart from behind, from above. That is what's important in this case. And instead of using the septum, we can look in the same way as we look in the Leiden classification for the coronaries. If you remember, we have to position ourselves in the sinus that is facing the other great arterial trunk, the pulmonary trunk. The same thing applies for these rules in topology. We have to place whatever we want, the hand or the glove, as to face the other ventricle. That's what it makes the key. Otherwise, I can use my left hand or right hand as I want if I use them in a 2D plane. But if I use the curvature, the embrace of the hand versus the other ventricle, then it all makes sense. Otherwise, if I use it in a single plane, I can use either hand. So we have to be careful with this. I use mutatis mutandis, the analogy with the Leiden classification, because the referencing of the two great arteries is important, not only one taken independently. The other thing, I understood your reluctance to use this topological definition in functional univentricular heart. But we have to think that we have there the interventricular communication that can serve as a surrogate for the inlet. And if there is always a rudimentary ventricle, we can still use, I think, we can still use the rule even in those hearts, because we have to place our palm or hand or glove as facing the other ventricle. So I really thoroughly enjoyed the presentation. I see it useful in the instances you mentioned, and I'm curious to hear other panelists' opinion. Thank you very much.
Well, thank you, Adrian, for those comments. you made the very good point that indeed we have had long-going discussions with Shijun Yu, who is one of the foremost imagers and who has promoted the notion of three-dimensional reconstruction. I believe that Shijun is with us and has been listening to all of that. Shijun, are you still with us?
Yes, I am.
Ah, there we are. Nice to see you.
Good to see
Well,
you.
you have heard the presentation. I don't need to tell you that you and I have had extensive discussions. We've both been up at night trying to grapple with the concept of topology. Do you have any further comments having seen what we presented today?
First of all, I would like to congratulate this trio ensemble in a major presentation. It's great, the morphology and overview and the really contemporary 3D imaging. It's just wonderful. And then I would really like to introduce what's my relationship with Professor Anderson. Believe it or not, I've been learning from him for last more than 40 years. And then my first personal conversation with you was just 30 years ago. That was on crisscross heart. And then we are communicating again in the last 1 month on this. So that's very interesting thing. Okay. And then I think you are not surprised that I always criticize you. So what I'm saying is that this is the topology, ventricular topology is fascinating and it applies for most of the heart. Absolutely, no question about it. I have two criticisms on this. The first one, once we know that, we don't need hands in more than 99.9% of the heart. In congenitally corrected transposition, in right isomerism, left isomerism, it is all about where the right ventricle in relation to the left ventricle with the ventricular septum, by yours, in neutral position. So then, why do we need to have your hands in imaging? So if your right ventricle is observes the left hand, that is the loop. If it is opposite, it's L loop, period. This concept is crucially needed when the ventricles have unexpected, very strange locations for the given atrioventricular connection. Typical is your crisscross heart. And then we named it together again as a twisted heart and supero-inferior ventricles. And then also hearts with disharmony of the atrioventricular connection and ventricular relationship. The problem I have is that whenever we have this complex heart, people and I have problem in applying this ventricular topology concept. And then ventricular topology concept was born to explain this. And then most of the people are having the difficulty. And then that's the point of my criticism. And that's why, if you look at the ventricular septum in neutral position, with the outlet heading toward the up in the screen, you exactly know where the right ventricle is on the right side or left ventricle is on the left side. Sometimes the supero-inferior, as you pointed out, equivalent position for that is easily appreciated. And then I have seen many really senior people, experienced people having trouble in defining ventricular topology in those difficult cases, not in regular cases, never. But however, problem is when we have these difficult cases. And what's the point? So that's my criticism.
But I think, June, that on the basis of the discussions that you and I have had together, is now the fact that each part of the ventricle has its own topology. And as I make the analogy to the hand, the thumb of the right hand will only fit on the right hand. So the right-handed tricuspid valve will only fit in the right-handed right ventricle. So now you don't need the septum because you have promoted the notion that as you've printed your hearts, as you say.
I did.
So if you print the tricuspid valve, only the tricuspid valve, that will now give you the opportunity to do what I've described as a three-dimensional jigsaw puzzle, because I take your point that it is only in these complex. You need to do it. Norman, stop coughing. The whole thing comes back. You just mute yourself at the moment. We need to see Shi Jun.
Could you allow me to show the case we discussed?
Indeed.
On the screen. So can you see the screen here?
Absolutely.
So this is the case with the twisted AV connection with left ventricle below and right ventricle above. So as you can see,
mute yourself. We need to see the screen.
You don't see the screen?
Yeah, it's come back. It's when Norman coughs, it goes automatically. Back to you now. Go again. Keep going.
Okay. Can I cough?
Yeah. Show us the heart.
So what I have in this case is the fact that what is that right atrium is in the back and then is pointing forward, and then septum is on the bottom, and then this side of the wall of the right ventricle is a parietal wall. This side of the ventricle is also parietal wall. So if I have here the endocardial surface reconstruction and print out and cut off the apex, and then you are going to have this. So what it is that the ventricular septum is a horizontal plane, and then the hole behind, so my finger is on the VSD. The hole behind is tricuspid valve. It is coming just toward you in this orientation. And then both this side and the other side actually free wall. So what it means is that in this particular case, right ventricular cavity is very symmetric. So it can easily accept my right hand and left hand whatsoever. So this is what I did. So this is the cutoff of the anterior wall of the right ventricle. And then you can clearly see it is going to accept your right hand, correct?
But the point, June, you and I have discussed this, and I have shown you. Yeah. You sent me the image of the right atrioventricular ring, and by that we can show that the tricuspid valve is still facing the mitral valve. And from the topology of the tricuspid valve, it is a right-handed tricuspid valve. And
that's not true. That's not true. So the reason why it is not true is that your septal leaflet is inferior.
But it doesn't matter whether it's inferior or superior.
Two leaflets are up.
June, it is facing the mitral valve.
No. Let me explain this.
No. You are missing. You have sent me the
No. You misunderstood.
No, I did not misunderstand. The tricuspid valve has still to face the mitral valve. The tricuspid valve, you say it has an exclusive endocardial border. That would be impossible.
So the facing the mitral valve is okay. Which leaflet would you call superior leaflet, and which leaflet is inferior leaflet?
It doesn't matter what this is. We're going to lose.
If I may intervene, please, because I think I can see where Shi Jun is trying to explain. But as I mentioned, this is about the embrace. You can use your right hand like this. Of course, you can use your left hand but it's on the other way. It's about embracing the other ventricle. Anyway, I'd like to ask the other panelists what is their opinion after seeing the presentation. So please, either Norman or David.
Norman, yes, you can come in now. Unmute yourself.
Diane is there.
Justin. I'm very sorry about my voice, but I have laryngitis and tracheobronchitis, so I apologize for my lack of speaking. I think that the points that are made are really very interesting with regard to the heart that is difficult to see. And Adrian, I think your point about the embrace is terribly important. I think that helps us. As far as putting my finger in the the old adage in clinical medicine is if you don't put your finger in, you'll put your foot in it. So I think that that is a real problem for me, because most of the time in usual hearts, I have no problem with putting my finger in. But I think that I would agree to some extent with Sijun, is that I can usually recognize a left ventricle from the right ventricle from a variety of ways, even when it's small. I have also a crisscross or twisted atrioventricular communication. And I think it becomes very difficult echocardiographically to look at that. So I think that the finger, especially in the cases like you showed at the beginning, Bob, where there was a tricuspid atresia, that first heart that you showed today, to my mind, there's no difficulty in recognizing that heart as a right ventricle, a morphologically right ventricle. And that's the time that I usually have a problem. And I think Diane showed a very nice support for your concept by showing a patient with an AV septal defect where there is no tricuspid valve, and showed that you could still recognize the morphology of the ventricles quite easily, even though they were in ectopic position. So, and of course they were mixed as well. But I think that solved the problem. The other thing I wanted to talk about for the 139 people that are still listening to this argument is the issue that we have gone back to our colleagues, the von Bragian colleagues that are with us, is that the hand topology and the loop are closely related, that they are one and the same thing that we're talking about, but we're not making an inference of the loop embryologically from what we see morphologically. Those are all the things I have to say today, and I apologize for my voice.
Before you go, why do you say we're not making an inference for the loop? Because I think we can make an inference for the loop. I think that the D loop, the L loop, we could now justify from what we know about development.
Yeah, okay. Well, I agree that I'm just trying to include the Van Pragians in our discussion here.
Indeed.
And there are many of them.
Indeed.
Unfortunately.
Hopefully the great schism can be resolved. But thank you.
I think so.
I hope you didn't catch Omni.
I just have a negative COVID from yesterday, so I'm still negative.
Well, that's good news, because you've got your cold and cough since you returned from the United Kingdom. But
yes, right.
Thank you.
I had 3 negatives in the United Kingdom as well, Bob.
Okay, well.
And nobody needs to worry, because I'm in my study and you're everywhere else.
Well, we have David Bolander with us today, and David is an anatomist who is now teaching development to the medical students in Wisconsin. David, having heard the complicated discussions today, do you have some comments?
Yeah, thanks. I come at this, like Bob said, from an educational perspective. First, I just want to say that, that Diane's videos and Justin's imaging, although I'm not used to seeing that imaging, but those really add to your presentation, Bob. So we're really grateful for that. As far as the topology discussion goes, I was confused about that when you started, and now I'm still a little confused, but on a much higher level.
I know.
Go ahead.
I note also that Justin has joined us. I know Justin has been very busy. Justin, you can unmute yourself, and you might want to make some additional comments on the light of what Shi-Jun was saying.
Yeah, I think you had involved me in the conversations with Shi-Jun, and I had expressed similar concerns as an imager, that when we do get into some of these more complex congenital heart disease cases, it can be challenging and often trying to understand the position of the ventricles related to each other seems to be somewhat simpler than trying to use the handedness. But then through these discussions, I certainly was convinced by your assessment of this complex heart, and specifically using, instead of the hand analogy, understanding it, and myself as a 3D imager, and really understanding the complexities of trying to understand complex three-dimensional heart disease by two-dimensional imaging. I appreciated that three-dimensional glove analogy instead of just the handedness. And I certainly was convinced by your assessment of not only the tricuspid valve morphology in that heart, but then using that three-dimensional glove analogy. But it still is a complex issue that I agree. I'm not sure I have 100% grasp myself.
It's a complex problem, and June and I will need to continue our discussions. But Diane, you're also with us. Do you want to unmute and give us your thoughts? Because having seen everything, and I mean, you've looked at lots of hearts over the years. Diane, are you there?
Yeah, I'm here. I don't, or I haven't had an issue with topology in the past, but I do think that the use of the glove and the more three-dimensional showing of how it can fit into the ventricle with the parietal aspect of the ventricle on the dorsal aspect of the glove could make it clearer for some people.
Thank you. I mean, this is something that we need to continue to discuss with June, because it's impossible, as he suggests, for the ventricles in his heart to be totally, for every surface, not to have a relationship to the other ventricle. And I think Adrian's point about the embrace is the important one. So June, if you are there, we should. Should
we give now the microphone to David, because he was mentioning something about his confusion. Please, David.
The question I wanted to ask was, where do you think discussions of topology fits in the medical curriculum? I'm thinking it's not the first year.
I mean, has made a significant point that in 99% of hearts, it's not important if you understand the notion of connections. And I agree with that. But for the overall understanding, to me, of congenital heart disease, then if you understand the notion of topology, you understand what is going on. And I come back to my hand again, because my right thumb only belongs to my right hand. I cannot chop off my right thumb and put it on my left hand. And so to me, the whole notion of topology, when we extend it to the rest of the components, recognizing that the right-handed tricuspid valve will only belong to the right-handed right ventricle. To me, this is part and parcel of the understanding. And that's what I've been trying to establish today. And I take the point that in 99% of cases, we're not going to need to go into such complexity. But I think if you understand that complexity, then you simply have a better understanding of congenital heart disease in general. And June, would you not agree with that?
So I think here there are three things important to emphasize. First of all, that ventricular topology and ventricular chirality, what Dr. Robert Anderson and Richard Van Praagh unanimously talk about, is very, very, very helpful in understanding. No question about it. I don't undermine that. The second thing that Bob and I disagree is the fact that there are exceptions. I believe I am right. You don't think there is any exception. I don't agree. I have seen significant number of cases where this topology wouldn't work. But that doesn't mean that because of these exceptions, I'm not discarding this. So that is the second. The last one is the fact that...
Let me stop you for a moment, if I may, because in that particular heart that you showed us, you agree that there is a D ventricular loop?
I believe so. But however, if I begin to use the hand, regardless of your new glove or the previous palm, it doesn't work that way, period.
Let me stop you again, because again, I come back. You don't need to go to the palm or anything now. You can simply use the thumb, because that tricuspid valve is a right-handed tricuspid valve.
Let me argue about that this way. If this is that difficult to understand, that concept doesn't work. If that is that difficult to understand.
I'm sorry, June, you cannot have that, because either we are right or we are wrong. And you can't say because it's too...
That is the continued debate, you and me. That is I think it's just the audience needs to know we are debating on this. That's good enough.
Yes.
The third one, I would say, last one is very important. This the thing in your hands versus screen or film or paper, completely different the scale of word. So this topology is sometimes, not sometimes, always much easier if you have in hands. But however, in the computer screen and in the paper, if you look at the literature, how difficult it is to understand, that should be recognized. And then we should have alternative way of understanding ventricular topology for clinical use, not the pathological examination.
But that's what we're trying to establish. And I put it to you again, that by expanding it, if you start playing with your glove, the problem with your hands is that your hands are always attached to your body and it's difficult to move them in every direction. But if you take the glove, I
have two words. I used to say that you clinical imagers, don't use your busy hands. You don't have to use, you can understand that. And the second is that I would say clinicians, you don't have to put your gloves in your pocket. You have your stethoscope and other things to put in.
If I may intervene, I have something to propose to the audience. First of all, if the audience could send us cases where they find topology to be difficult, I'm sure they all have in their cases such examples. They could send us, and we should look at them, and they will come back with a session on these difficult images. And Shujun, the same with you. I will email to you, and we can find these examples, and we can look at them. And I think this will be very useful for the audience to see the theory that we discussed today applied for their own cases. Would you agree?
The point you make there, Adrian, is a very good one, but also June has the capability to he has already printed his heart, and that tricuspid valve, this is where I come back to development. Because when that tricuspid valve was formed, before it started twisting, it would have had a septal leaflet. It had to have a septal leaflet because it divided itself from the atrioventricular canal. So June has the capacity to print that tricuspid valve, and I will bet 100% that if he prints that tricuspid valve with its septal leaflet, with its anterosuperior leaflet, with its other leaflet, which will not be inferior because it's been twisted, but it will have another leaflet, then that tricuspid valve will be a right-handed tricuspid valve, and that will be the proof of the pudding.
I'm sure Shijun will agree to send us the 3D prints for us. The Congenital Heart Academy will sponsor the poster. Price, and we will all have those 3D prints. This is important for the audience to know that the 3D printing is very useful in these cases. Would you agree with that, please?
I mean, we don't necessarily need the printing. We only need the data set. I mean, just manipulate the data sets.
Sometimes it's easier to send the print instead of the large data sets, but if the data set can be shared, that also is fine.
Justin, do you have any thoughts?
I have nothing further to add. I think Adrian hits it on the head that it's hard to discuss these things and better to show examples.
But you would agree that we should share our expertise, and if June is up for that, and I think Adrian's point to have a collective if we can, if we have, because
I will send it, Justin, that here the original image is set, and then that is the good starting point. And then your actually 3D endocardial surface imaging is almost a specimen.
Yeah.
Yeah.
Okay.
Yeah. But I do agree with Shi-Joan, just to emphasize, this is difficult for the imager. This is different than if we have the heart specimen in our hands and can manipulate it, or even difficult if we can make a fancy 3D data set, virtual data set or printed version that we can manipulate, which is not always the case in clinical practice when we're relying on two-dimensional echo.
What I would suggest it also, and this is a good point, Justin, if we get the cases in terms of the data files and the imaging, I liaise with Diane to get specimens that will mirror those. So we can work together with specimens and the data and the 3D prints.
I have to at this point apologize to our audience, because I see that some of our participants are raising their hands and I do not have the capacity. I apologize to everybody who is raising their hand. It would be very nice if we could involve you in the discussion, but I don't know how to do it.
So I put my email in the chat to everyone to collect all the questions, and I will send the questions to the panelists once they send me via email.
So I apologize. I mean, it was I was discussing earlier today with an old colleague of mine who said that the discussions in these tend to be a get-together between the panelists, which is indeed the case. And I apologize to our audience that I can't involve those of you who are trying to raise the hand. But I think Adrian's suggestion that we should expand this and we should see what comes, and we, through the Congenital Heart Academy, will try and coordinate another discussion. Adrian, we're still with you.
Yeah. So I think if there are no other questions, if the other panelists, do they have any other questions or comments? It's been a long session. It's almost an hour and 45 minutes on a difficult topic.
Well, but I think that the comment is important, is that what we're arguing about is the very tip of the head of a pin in terms of the overall issues that Bob has shown us today. I mean, for 99.9 recurring percentage of time, this is not an argument at all. It's just for a very, very small number of things, and people shouldn't be confused that what has been described here today is accurate and reliable in almost all cases that we've seen. And we're really arguing about a very small number of possibilities.
This is certainly true. But I still do think that if you understand this concept, it broadens your understanding of congenital heart disease in general. And I think the basis of what we're trying to do is to share understanding, and to link it to the development, which I think is now possible.
Yeah, right.
Anyway, as Adrian said, it has been a long session today. I think it's been very worthwhile. I'd like to take this opportunity to thank everyone for joining us. We're coming up to the festive season. In the United Kingdom, we are overwhelmed with Omicron. So if it hasn't reached the rest of you yet, I fear it is going to reach you very shortly. So I hope it is much less virulent than Delta and Beta and the starting point. And I hope we are all coming out of this pandemic. But next year, the one thing that has come out of the pandemic, which is a great advantage, has been the Congenital Heart Academy. I think you would all agree we've had a great time working with the Congenital Heart Academy. We will continue in January. As I say, the first two sessions are going to be on the valves, hopefully not as controversial today as it was today. And then we will start with the malformed heart. So I wish everybody a very positive festive season. Enjoy yourselves. And I hope you will all join us again in 1922. So thanks to everybody for joining us, and happy Christmas and a happy New Year.
Thank you. The same to all of you.
Thank you.
And bye.
Thank you.
Thank you.
Bye.
Bye.
See you.